So good morning. This is about ovulation induction. WHO classification, we have three groups. The fourth group is hyperprolactinemic and ovulation. Pre-treatment evaluation for the glycemic status, OGTT is preferred to diagnose impaired glucose tolerance and to diagnose early type 2 diabetes, whereas fasting and HbA1c is enough for other patients. HSG and ultrasound is indicated for women more than 35 years. Lifestyle changes has to be done before starting ovulation induction. Weight loss need to be done. First drug, clomiphene citrate. It is a non-steroidal triphenylethyl derivative. It is indicated for class 2 anovulation, that is normogonadotrophic and normoestrogenic. It has a protocol called stair-step protocol. So after menstruation, on day 5 we start 50 mg given for 5 days. So day 5 to day 9 we give, and then on day 11 to day 14 we measure the ultrasound, the dominant follicle. The dominant follicle has to be of 22 mm size. If it's not there, from the next cycle they increase the dose to 100 mg. If the desired response is not achieved, then they go for the further increased dose 150 mg. So this is called the stair-step protocol. Start with the low dose in the first cycle, then it is increased. If pregnancy is not achieved within 3 to 6 cycles, extend your evaluation. Prolonged treatment is inappropriate for age more than 35 years. Side effects: scotomatopalynopsia, photophobia, multiple pregnancy, miscarriage, ovarian hyperstimulation syndromes. Adjuvant combination: clomiphene can be combined with the DEXA, prednisolone, HCG, metformin, or it could be given with a preliminary treatment with the GnRH agonist and ocipils. The second one is aromatase inhibitors. It is off-label use only. It is not FDA approved. It has favorable molecular profile. It stimulates the integrin beta and alpha. It is ineffective in WHO group 1, and it is given on day 3 to day 5, and the dose increments can be done in the same cycle without inducing bleeding. The third method is laparoscopic ovarian drilling. It can be done by electrocautery or laser vaporization. It should be avoided at tubo ovarian surface. 4 to 6 sites. One unilateral is better than bilateral thing, and FSH will rise. Inhibin, androstenedione and testosterone will fall. Then gonadotrophins, we have recombinant and HMG. So LH promotes the final stages of follicular development, and it helps in luteinization, steroidogenesis and ovulation. It is indicated in hypogonadotrophic hypogonadism, that is WHO class 1. Second one is clomiphene citrate resistant anovulation. Third one is unexplained infertility. We have 4 regimens. Step up regimen, starting with 75 for 4 to 7 days, and then measuring the follicle size. After the follicle is 20 mm, give HCG injection. Low slow treatment regimen is given to patients with PCOS. They respond maximum to a limited dose of FSH. So even a small dose is highly sensitive in these patients. So we give a small dose, but for a prolonged duration, that is 7 to 12 days. Step down treatment, begin with 150 to 225 international units, and then reduce it just before LH, decide the date of LH surge. So with this gonadotrophin, the cycle fecundity is 25%, and the cumulative pregnancy rate after 6 cycle is 90%. Miscarriage rate is 20 to 25%. It is high in PCOS patients than in normal patients, but there is no evidence for congenital anomalies, and the side effect is ovarian hyperstimulation syndrome. Pulsatile GnRH. GnRH has a half-life of 10 to 40 minutes. So it is given as a IV 2.5 to 5 microgram per pulse at a constant interval of 60 to 90 minutes. It is indicated in anovulation in a hypogonadotrophic hypogonadism, that is WHO class 1. Last is the dopamine agonist, hyperprolactinemic infertile women. with ovulatory dysfunction. So bromocriptine and cabergoline. Bromocriptine is given orally and it has action for 12 hours. When it is given vaginally, the action is extended for 12 more hours, so that is 48 hours. Begin with a dose of 2.5 mg, maximum of 10 mg is needed. Cabergoline started with a dose of 0.25 mg, maximum of 2 mg, and it is given once in 4 weeks. So the frequency of dosage is less, so it is convenient to the patients. But this causes serotonin activation in the heart, so it will result in regurgitation lesions. Bromocriptine will not cause this serotonin activation, so it does not have that heart side effects. Thank you.